Good evening, folks. Hey, I just want to double check, make sure everybody can hear me real quick. If somebody can put something in the chat saying that you guys can hear me, and just let me know. All right. So again, I'm hoping everything works offshore this time. So let's pray that it does work. Um, if it doesn't, somebody please just key in and kind of let me know that something's going on. I'll try to pay attention to the chat, make sure we're good to go. Gonna get started. I know there's a couple of people, only for you guys, counting myself in here. And if there's an issue, I'm sure some people are, unfortunately, because of the snow down south. You know how snow bunnies down here don't have no idea what's going on. So it's caused a lot of issues. So it's when we have it set up the way we do. You can listen to it and all that other stuff. If anybody needs to go, just let me know in the chat that you have to go or bow out, and you'll have to get the information later. Starting right along tonight. I hope everybody's doing well. It's really really cold offshore, so we had pretty good winds yesterday. It was about 60-mile-an-hour wind, so we had all sorts of fun. Whoop, wrong button. All right, so we're going to start going over tonight with respiratory, the National EMS Education Standard Competencies, medicine. Um, I'm trying to make sure I'm even on the right slides, guys. For some reason it just looks weird to me. Give me 2 seconds. I want to make sure we're good to go. All right. Yep. All right. So it applies to all fundamental knowledge to provide basic emergency care and transportation based on assessment findings for actually acute patients. Um, so we'll go respiratory. We're going to talk about the anatomy, signs and symptoms, and how we treat these. Even though it's in our management, but what are we going to do for them? What it affects the upper and lower respiratory. We want to kind of go over all that. And then we're going to talk about anatomy, physiology, pathophysiology, assessment, and management. We're going to show you the epiglottis, spontaneous pneumothorax. We're going to talk about pleural edema, asthma, all this fun stuff, COPD, chronic obstruction, pulmonary disease, all these fun things we're going to hit through the night, kind of go over a lot. Yes, it's going to be a lot, but hopefully I can try to break it down. And as y'all saw, if I don't know if y'all saw already, I'll have some questions posted to the Facebook page after a while. Hopefully, we will get that situated and you'll be able to go in there. Um, so, now we're going to talk about more things we're going to go over is anatomy, pathophysiology, assessment, and management continued, environmental industrial exposures, toxic gas, bursitis, cystic fibrosis, PE, pulmonary embolism. We're going to also cover some pneumonia and viral respiratory infections. So I can tell that's kind of getting to me on that word. All right, so go over this. So patients often complain of dyspnea. So when we have somebody with dyspnea, there's going to be shortness of breath and difficulty breathing, but they're going to have like what we say, and I've said in the past, just one or two word dyspnea. They're going to have trouble talking. So when they do talk, it's I can't breathe real well. So it's every word they're having to take a deep breath. Dyspnea can be caused by so many different things, just the regular common cold, asthma, heart failure, and well, PEs. I mean, that's some of the things there that can cause that. Dyspnea can be difficult to determine. Several different problems may contribute to a patient's dyspnea at a time. Like me, we're out here on the platform. We got 6 flights of stairs. I'm gonna tell you, if you all the way at the bottom and then you got to go up to our drill floor, bro, you're gonna be hitting like 300 flights of stairs. I know I said 6, but there's a lot of twists and turns and all that. Man, whew. I'm gonna tell you, I get a little difficult to do it too. So we talked about the different conditions. It can be difficult to determine. It may just be, are they winded? What's going on? Are we having trouble? Just like, let's put some oxygen on you, and we're gonna figure out what's wrong with you if you can catch your breath. Well, the ones that just don't catch their breath, that's where we got to figure out and we got to work on and go dig a little deeper. The respiratory systems includes the structure, basically what falls in the respiratory tree. Your diaphragm, you have your chest wall muscles, accessory muscles of breathing, nerves of the muscle. Those are important too. This one's that makes things move. It tells you to breathe. It's a non-automatic response that just our body automatically does. If anybody ever cares about that, that's kind of cool to find that information um, about just what things that the body just automatically does without us having to think about it. I mean, because y'all can imagine some of us are simple-minded people. We know some people that we just wonder how they even walk. What can you imagine trying to carry out your normal daily functions and remembering, oh crap, I gotta breathe? Well, that's going to cause issues for all of us. So just think about that. That's pretty neat that our body automatically does that without us having to even think about it. But got to get my cursor in the right spot. All right. So the airway consists of structures. We talk about the lower tree and the upper tree. You got your nose and mouth. I'm hoping everybody has learned that in your time alive where your nose and mouth, jaw, your oral cavity is. Then you have your pharynx and larynx. We'll show a diagram in just a second that'll break it down to you if you have questions about that. Bam, look, there it is. So your upper airway has the four parts: your pharynx, your mouth, your epiglottis, and larynx. So let's. I'm trying to. I found this neat little thing earlier, so I'm gonna have to try to. I'm gonna try to use this. So right here, that's your pharynx. And down here where it gets real small is your larynx. Sorry guys, little things I'm making right there, finding the highlighter and all that. So then we'll drop down to our lower tree. So now if you didn't have an idea of where these parts are, it'll show you you have your trachea, and then it's divided to the left and lower lobes. Right here, it's where your ET tube for paramedics when you tube. It'll sit right in here. Yeah, that looks like a super long ways, but it's not really that far. Right in here, you have your bronchioles, and then you have your main tree for your bronchi. It sits right here. This is the main part. Your bronchioles break off the bronchi, and then your lower breaks it down even further on the side down here. Your pulmonary capillaries and your alveoli. That's what's really important. Those are the ones that hold your oxygen molecules. Those are the ones that break it down and helps us breathe and gets the oxygen into the systems. Here, we'll show right here on this one. Oh, sorry. Looks like my highlights carry over. Let's get rid of that. All right. Lesson learned there. Principal functions of lungs and respiratory. Well, we know what they are. I hope you all know what they are. It's the exchange of oxygen and carbon dioxide because we've all had a good fair life so far, and I'm addicted to breathing. That's pretty real. The only thing that I'm addicted to in life is breathing. That's what gives me to go. So we kind of have ideas on how that functions, what our bodies are, what works for us, and so. So the air travels through trachea into the lungs. The bronchi is a larger airway, and the bronchioles. See if I can go back to this picture right here. So, whoops, sorry guys. So you breathe, your air comes in here, goes down into your lungs, but then is broken down into your bronchioles. So that's this part. If you look at this little bitty picture, that's your bronchial tree right there. Then it breaks off into these. So your alveoli sits on top, but then that's where the exchange of oxygen actually takes place. So right here, as everybody can see. So these are kind of some important questions right here. What is the process of oxygen? How does oxygen move through the body? Um, where does the actual exchange take place for the oxygen into the lungs? I mean, if that was to write a test question, that'd be a pretty good one, in my opinion. Um, so these are pretty important to us. Respiratory process, you have two processes. You breathe in and you breathe out. Inspiration and expiration. Again, that's very important. That's the two processes of respiration. Oxygen is provided to the blood. So we have blood enriched oxygen enriched blood, and then we have once it goes to the heart, it drops it and comes back out, and all this stuff. Then you have oxygen depleted blood. So then right here where it says oxygen is removed from the blood, and it takes place rapidly at the alveoli levels. Expiration is the act of breathing out or exhaling. We should know that. I hope y'all know that to this point. Then in healthy lungs, the exchange of gases takes place rapidly at the alveoli. So we're cleaning the blood as it goes through the heart. We're taking the oxygen out of the blood when it goes into the alveoli. So you see that these guys, is so fast that we don't have to think about it. And it still blows my mind, if y'all can't tell, I'm harping on it, that it just does automatically and we ain't got to worry nothing about it. Here gets a little bit deeper, y'all. So, I'm trying to get my cursor on the right spot. So the blue lines everybody sees on the far left picture is going to be our arteries. The red ones are our veins. And they're all attached up in there. And so, see where it says number one, deoxygenated blood is carried from the heart to the lungs by the pulmonary arteries and the arterioles. So it breaks it down. So we're going to have clean blood, and I'll call it dirty blood, which is deoxygenated blood. And we're going to clean it, put oxygen in there, and that's how we move CO2 and oxygen throughout the body. The gas exchange takes place at the capillaries and covering the alveoli, right here on number two. And number three, oxygenated blood is carried from the lungs to the heart by the pulmonary veins and venules. Bruh, that is a lot. I mean, think about how fast that's moving. On this one right here, you see where it says the blood cells, and then you have your capillaries on the outside. You see how your oxygen and nutrients are coming in right here, and then your carbon dioxide washed back out. So on your pictures, it's sucking into your tissues. We're dumping it in, and then we're sucking it out. So that's how we get rid of our CO2. It's through the blood, and it deoxygenates and oxygenates the blood. Thank God this is all done, because we would all be in some serious trouble. I keep resorting back to, we all know that one friend that would just, I don't know if they'd still be around, because they'd have to think about it. All right, so in the alveola, oxygen passes into the capillaries, carbon dioxide returns to the lungs. Let's see, it is then carried to the heart, which pumps the oxygen throughout the blood. Carbon dioxide returns into the lungs. Oh, and then it diffuses back into the alveoli. I kind of look at it as you've seen how people diffuse certain things to get certain scents and all that. That's kind of the way that I remember it. Is carbon dioxide is infused back into the lungs, so it's a slow process. Even though it's quickly done, it pushes it through there, and then the oxygen's pushed out. It travels back up to the bronchial tree, and it exits the upper airway during exhalation. So we're breathing it right back out, even though we're taking deep breaths, blowing out, deep breaths, blowing it out. It's done so fast that I mean, to break this process, I actually found a video on YouTube that I want to show you guys, but it was like 30 minutes long. And I was like, I got bored watching it, so I didn't worry about that. If the level of carbon dioxide drops too low, so the person automatically breathes at a slower rate and less depth. It clicks in. The body's like, all right, I need to slow down. We're gonna do this. And then it says as a result, less carbon dioxide is expired and levels in the blood return to normal. So that's why we'll do like a put them on let's see, we'll put them on high flow O2. We need to dump the CO2 out of the body. If somebody's been exposed to a high dose of CO2, you want to give them fresh air, move them to fresh air, put them on supplemental oxygen, which will help get that CO2 out of their system. Because CO2 is deadly. You can have them exposed to somebody give me an idea of what exposure of CO2 is that can hurt somebody. But this is something that we can do and move them out to fresh air, and it helps just quickly. If the person breathes more rapidly and more deeply, more carbon dioxide diffuses out of the bloodstream, and levels of blood are thus lowered. So that being the case, all we gotta do is just move them. It's all fumes. Good job, Travis. Matter of fact, I read somewhere in the news a little while ago that a mother and a child died in Texas because they were sitting in the car trying to stay warm because they didn't have power. And obviously it was in their garage, and she didn't think about opening the garage. And unfortunately, they're no longer with us, which is a very sad thing. But good point. That can happen. So the pathophysiology is the proper exchange of oxygen and carbon dioxide can be hindered by abnormal pathophysiologies in the anatomy of the airway. We have disease process, traumatic conditions. They may just had a massive issue, and now they got a hole in their lungs or a puncture, and they just can't hold air. So now we're having issues doing with the CO2 exchange. Then you see their pulmonary vessels, which may have abnormalities that interfere with the blood flow. We just talked about that for the pulmonary vessels. So any little thing can affect this. You got to realize it's an enclosed process. So anytime you expose the process, and it's either by entering something into the body, a foreign object, to the airway of any possible way that blood flows and or air goes in and out of the body, you're going to have issues. Let's say the person loses a lot of blood. Well, now we're going to have issues with the respiratory system also. They can go into respiratory distress. Uh, at the last worst resort is respiratory arrest. So those are the things that we got to realize is that, oh no, what are the signs and symptoms that are related to movement of carbon dioxide in and out of the body? So we want you to recognize the signs and symptoms of inadequate breathing, which I hope that you all know. Be like, oh, they breathe in like 4 times a minute. That's not good. So those things that we hope that you already know, that is what to do for it. What are we going to do? Know what to do about it. If carbon dioxide retention and hypoxia drives, what are we going to do there? A patient will sometimes have an elevated level of carbon dioxide in their arterial blood. Potential causes, we talk about exhalation process may be impaired by the lung disease. So if they're some people are always going to be on a CO2. Sorry, I'm reading ahead. If they're already going to be on oxygen because they do have that lung disease and they're already having trouble breathing, so their CO2 may be up in their body. See where it says right there, chronic carbon dioxide retention. So you got to be very careful when you give them oxygen because you can cause a lot more harm by trying to up their O2 levels when it's not going to get that high. Let's say if levels stay high for a period of years, the respiratory center in the brain may not function properly. It could significantly signify chronic carbon dioxide retention. The brain gradually accommodates high levels of carbon dioxide and thus uses a backup system to control breathing based on low levels of oxygen known as hypoxic drive. Use caution when you give O2, like we just talked about, because the body is so used to that already, and then you start flowing them with large quantities of clean air, and their body is going to shut down on you. And that's something that we definitely don't want to do. We want to treat the person with the best abilities, not really cause harm, but people that have these issues are going to already know, and they're going to let you know that they have a lung disease. And I've never dealt with one of these. I've read about it from a couple other colleagues out there that's done studies on this. So the patients are going to already let you know. Patients also often have dyspnea or hypoxia with PEs, pulmonary edema, hay fever, which we know that's all everything's COVID right now, but you can still have the flu and hay fever because the seasons are getting ready to change. You can have pleural effusion, obstructive of the airway, hyperventilation syndrome, environmental industrial exposure, or drug overdose. Let's see what else it shows me. All right, go to the next one. Dyspnea patients may have they have gas exchange between the alveoli and the pulmonary circulation is obstructed by fluid in the lungs, infection, or collapsed alveoli. So those are highly important that we want to try to keep, you know, get them some oxygen because they're already having trouble. And sometimes it may be easier to have this person write to you if you realize that up early. Let them start writing. Let's see. The alveoli are damaged and cannot transport gases properly across their own walls. The air passages are obstructed by muscle spasms, a lot of mucus built into the lungs, floppy airway walls. They may not have had developmental issues when they have those issues when they're coming with their lungs. So if they were let's say a preemie that didn't have enough surfactant in their body, even though they push surfactant into the body when they're young and they notice that, they may have already come up that way. They may also have blood clots in their lungs. And then the worst part that you got to worry about is the pleural space being filled with excess fluid. It could have fluid, it could have air, but they can't do a properly expansions of the lungs to get them our deep breath. So when everybody's sick and you say you got the flu or pneumonia, and they're like, all right, take a deep breath. Bruh, I am. But they put you on this little mini machine, or you got to blow the ball to a certain level. It's like a respiratory physical therapy that you got to do if you're ever into the hospital. That's to help build your lungs back up to capacity and the ability for them to get bigger and stronger. Um, I wish I could remember the name of that little machine, but it's pretty neat. I had to use one several years ago. Had some issues with my heart and had to stay in the hospital for a little while. But they put you on this little machine and they do it like 3 or 4 times a day, and they're like, "Gotta breathe deep, gotta blow hard," and you can't. It's just it sucks. It's you got to do your best to get it there. All right, so if you look in your book on table 15-2, this is really cool. If you got it there handy, you can look at this. Here's just some telltale signs and symptoms of respiratory problems. I'm not going to read them all, but so the skin is pale, cool, and clammy. Are they cyanotic? That's pretty nifty. That's a telltale sign that you're like, oh, what's wrong with them? They could also be having chest pains. That may be another big issue if they're having the cyanotic, the clammy. The patient has unequal, inadequate chest expansion. That's a big one. If they're just taking short, shallow breaths, rapid, they're having irregular, regular respirations. Instead of having regular ones, you know that they're just, hey, that's not right. But they're on a certain pattern. So that's where you get your irregular, regular. The patient is coughing excessively. Unfortunately, that's a sign of COVID here days that everybody talks about now. So we're going to go over the COVID symptoms. The patient has pursed lips. So it's like, so you purse lips is you push your lips real hard together and you try to blow. It's like, if y'all know what I'm talking about, I'm sitting here looking at the screen like an idiot trying to do it so y'all can see me, and I'm just not going to turn my screen on and let y'all see me do that. That's a little embarrassing. Or you see their nasal flaring. So it's the same thing. Their nose, it looks like they're short of breath, like somebody that just ran a quarter mile, half mile, in my case, 100 yards, something like that. They're going to start having their nose is going to flare up to get more oxygen. Let's say, and then they obviously tell you that they're having trouble breathing. I can't breathe. It's shortness of breath. That's a sign of dyspnea. 1 or 2 word dyspnea. We talked about that. If you look on table 15-1-2, it'll tell you the respiratory rate is either too fast or too slow. And what I'm pretty sure that they're going to show is the respiratory rate 12 to 14, 12 to 16, how many breaths per minute for the adult, child, and pediatric. I'm just guessing that's what it's going to see. Haven't seen a book in a hot minute, but I bet you that's what it is. Just a breakdown of the table. Chase, is that the machine that you're talking about? The incentive spirometer? It's one I was trying to remember. Because it's them that sounds like you on it. Yeah, Chase, that's I don't know. I hope you hadn't had to use that thing, but I hated it. It did its job. Don't get me wrong, and I hated the young little girl that did it. But she makes you blow on it, and it works really good. It works you out. You get tired after it. Um, so some cause of dyspnea. May have chest tightness, or they need some more air. Travis, yes, you inhale that one. There's one that you exhale on. My dad is on both with COPD. Man, I'm sorry to hear that, Travis. They do suck, but they do their jobs. They do help give them that physical therapy. I'm sure he hates it. He's probably fusses about it every time he has to do it, but unfortunately, it's probably for the better for him. Works on it. They've kept him from getting pneumonia with COVID. Man, that's awesome. I'm gonna tell you, I had COVID the week right before Christmas. My wife and I both had it, and man, the breathing problems were really bad. I had back pains, the muscle aches, and my knee, like my right knee, swelled up like double size, and that junk hurt. I don't wish that on nobody. I know we've all lost somebody or know somebody that's had it. COVID is real, and there's some things that I urge you to do your own reading, your own education about that, but understand that it's very, very rough. And unfortunately, Travis, I'm glad to hear that they've kept him from getting it, but I wish him the best. So we'll talk about this one. Common with cardiopulmonary disease. So besides shortness of breath, the patient may be dyspnea. We talked about that one. Congestive heart failure causes the heart to pump inefficiently and deprives the body of oxygen. Again, we know we're going to see that because they already do have CHF, which is their congestive heart failure. They're going to have excess fluid on them. It's the patient's going to be uncomfortable. You're probably going to see these a pretty good bit. Pulmonary edema is a condition associated with CHF. The feet are going to swell. They're going to have cankles. Maybe a level 2 of edema, depends on how deep. Some agencies may let you test for the edema and on the depth and all that you can push in. Most of the time that happens at the hospital, but edema is pretty bad. It sucks. It's painful from what I hear. Let's see. Severe pain can cause a patient to experience rapid, shallow breathing without the presence of primary pulmonary dysfunction. In some patients, breathing deeply causes pain because it is an expansion of the chest wall, and it hurts. I mean, you gotta think they're used to, and for them to take the deep breaths like all of us tried our best to do, that's not what their body is. It's like us kind of go to the gym after the first week, and you sit down to use the restroom, and you're like, oh my God, my legs won't let me move. It's the same thing, but for them, it's their lungs. Can you imagine trying to take that deep breath when your body's all sore and you're like, what in the world? I hate life because it hurts so bad. Um, Infectious diseases may affect all parts of the airway. Some form of the obstruction causes dyspnea. Mucus is a big one. We all know that. Even when we get sick with just the regular common flu and cold, we get that cough and that mucus comes up and it's like, oh, that hurt. Everybody knows that nasty cough. Um, it hurts to breathe because this is obstruction airflow in the major passages. You have swelling of the soft tissues, impaired exchange of the gas alveoli. The problem causing dyspnea is airways is always some form of obstruction. It could be mucus, it could be secretions, obstruction airflow in major passages. It could be a cold, diphtheria, swelling of soft tissues and upper airway. You could have epiglottis or croup, impaired exchange of gases in the alveoli. The biggest one that I can tell you right now is pneumonia. And be very, very diligent about use of a proper PPE when you're taking care of these people, because if it's infectious disease, you don't want it. You don't want to take it home, and I highly recommend, highly, if you go and take care of anybody that you know, and I've tried my best to be in a good habit of it. If I work the truck or if I'm in a in a LEO unit or wherever I'm at, I don't ever like to take my boots in my house. That's just gross. Because you don't know where those boots been, what's been on them. We're not habits of cleaning our stuff, so those are gross. Miss India says, I've heard of people having arthritis of the chest wall and causes pain and shortness of breath. Now, I don't doubt that. I can't tell you that I have, but I can promise you several people. Um, just an age is an issue. And it hurts, and it may be the arthritis because they're always breathing like that. So I'm not gonna argue with you. I can see that it's probably painful. It hurts. I know I've got arthritis of the knee, also from a lot of my stupidity when I was younger. So I can't imagine having it in my chest on how rough that's gonna be. That's gross. I mean, it's horrible. It's horrible because it's excruciating pain. Um, so we'll talk about inflammation and the croup. So the croup is what's really going to affect your younger age, kind of to your teens. Um, so the way we break it down is so croup is 5 letters, same thing as virus. So it's a virus if it's a croup, but if it's epiglottitis, it's an infection. That's the way that I always remember it. It's helped me out through all these years. Inflammation and swelling of the pharynx and larynx and trachea. So all this, sorry, I was on another screen. All this area right here is what's swelling. That's the reason why you hear the seal bark cough. I can't do that for y'all, so I hope y'all don't ask me to do it because it ain't gonna work. But then you have that real loud. Hey, I'm gonna stop. That's enough. Um, Humidified oxygen really works good for those. We actually have a humidifier offshore that we only have one, so we try not to keep those patients with us, but we've gotten these new high-tech UV black light HEPA filtered charcoal machine. I don't know. They're massive. But they've been very good. But anything nowadays that somebody has, even the flu, they're not staying offshore. Back in the day, we would used to kind of babysit them and go from there. But now, like your younger kids, you want it humidified. Um, it does help. Just it doesn't have to be warm or cool. Just humidify the water and push it out in there. Travis, yeah, those HEPA filters are awesome, especially if you come in contact with a lot of virus and bacteria. We jokingly say that we're a floating petri dish because we have people from all over walks of life, all different aspects of work. They work 24 hours a day, 7 days a week out here. Doesn't really matter the weather, but since COVID has kind of stopped all that, so now we test people prior to coming offshore for the COVID, and any form of somatoception that you start to have respiratory issues, I automatically test you offshore for the flu. If that's positive, you're leaving, or if it's negative, you're leaving. We still have a quick rapid test offshore for the COVID. We also have a company that's out here doing that right now. Um, and as of today, we've tested 758 people since January, and our platform right now is, I'm knocking on wood, it's still clean. Some of our other compadres within our company can't say that. But back to this. So croup, it's really big for kids. They get it back in here, and they swell down in this area. So you may, if you have that call with that child, you may have to build that trust for them, for you to be allowed to fill their throat, and you'll notice it's just, you're like, ooh, that's thick, that's kind of swollen. So and then we'll go ahead and change here. So you'll see down here, it narrows and their epiglottis is swollen. That's the reason why I see right in there the airway obstruction. It's a bacteria. This makes the epiglottitis swell. Children are also found in a tripod position. So imagine standing on your two legs, lean over, grab a hold of the table with one arm. A lot of times you see them with one arm because they take that other arm and they're trying to stretch and make their chest wider. But it's also that you'll see them in a barrel type position. I've seen them both times because they're striving for oxygen. They're just not getting enough, and they provide. If you give them oxygen, a lot of times it will help them, but you're going to have to do it on high flow that's tolerable for the child, and sometimes they may not want it over their face. So, but you're going to need to keep a blow by, but it's pretty close. So it's more predominant in children, but it's also, you can find it in adults. Haven't seen it a lot in a while. It's a quick onset. Children look ill and report very sore throats and a high fever. And remember, anything with a high fever over a long period of time, that can also cause brain damage that we don't want. So cooling of the children can also help. We talked about the tripod position and drooling, and the reason why they don't want to swallow is because it just hurts. I mean, they got this big swollen thing right. Where's my mouse? Right here. It's just swollen and it's blocking all the spit up, so it's easier for them not to just swallow at all. Um, so you treat the children gently and try to make them, try to not make them cry, because it's just going to make it worse. It's like aggravating swollen area. It's cool. So try to get the trust of them. If a parent's around and the only way they'll calm down is with the parent, so what? Let the parent hold them and transport them to the hospital. You want to make sure they're comfortable. Like I said, we talked about a while ago, provide high flow oxygen, and just try not to let them put anything in their mouths. I know that sometimes that's really hard to do, but it's for the betterment of them because they can't swallow anything. It's all blocked up. Then we get a little bit worse. We talk about RSV. Everybody's heard of RSV. That's very common in of young children. It's a cause of infection in the lungs and the breathing passages. It's highly contagious. Kids get very, very dehydrated from this. You want to treat them pretty quick. You want to jump on that, and that's something if you're not on an ALS unit, you want to get an ALS provider there pretty quick. And if worst case scenario and they have to secure the airway, you don't want to have to let them go into distress or arrest and then call for a advanced provider. You want to try to go ahead and think ahead, because if the parents tell you they've been diagnosed with RSV, hope to God you're close to a hospital. And then my next question is why are you home and you're not at the hospital with this child with RSV? Again, they take humidified oxygen is very helpful. I just be very. I kind of treat RSV like a uh, contagious. It's an infectious disease. You kind of put the gown on. You don't want any mucus on you. It's just, again, you don't want to take that home to your family. If you happen to have a small one at home and you've taken care of somebody with RSV, leave your clothes outside. Let them just sit there. Travis, does RSV usually only happen in kids, or can adults get it as well? I have only come across of it with children. I haven't seen it in adults, but I tell you what, let me just check. I have a so RSV can also infect adults, and adults and older healthy children. RSV symptoms are mildly and typically mimic the common cold. Self-care measures are usually all that needs to relieve the discomfort. So yes, adults can get it, and they can get it by being around somebody that's contagious. Um, so you'll look for runny nose, sore throat, mild headache, sometimes fever. But right now, when I describe those symptoms, what's that sound like to y'all? Runny nose, sore throat, mild headache, cough, and sometimes fever. Exactly, Travis. That's unfortunately everything in the world. Even if you have a trauma with a guy's right arm cut off, it's COVID related. I don't know. Mac, the Rona, you're right. It's frustrating as a healthcare provider. I understand why they do it on the management side. Doesn't mean I have to agree to it, but Travis, I'm gonna let you just say yes. Yes. Adults can get it too, but I'm gonna change topics because I'll rant on that for hours. So, talked about that. So, yeah, Mac, you said it right there. Money, 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 money. Um, Bronchiolitis is a viral illness often caused by RSV, um, and it usually affects newborns and toddlers. So that's where we get a little bit more serious. It becomes inflamed, swelling, and fills with mucus. It's very gross. They have to be suctioned out all the time. They could be on a tube, the ones that goes in their nose, a nasal tube. Provide oxygen therapy frequently for signs of respiratory distress. And children, newborns, toddlers, they're going to crash fast. Just FYI, don't hesitate. If you feel like you need to do it early, do it early. Don't wait, because by the time that you're ready to do something, it's too late. Bronchioles become inflamed, swell, and fill with mucus. We said that. It's just, I can't knock on the table enough to tell y'all that you need to jump on children's fast, especially if you know that they've had RSV and they've been discharged. Be prepared for that. Um, there we go. So bacteria, it's a general term that refers to an infection of the lungs, often a secondary infection that begins after an upper respiratory tract infection. It can be caused by a virus or bacterium, or by chemical injury or direct lung injury. Bacterial pneumonia, we've all heard people get that, will come on quick as a result of a high fever. Then you got viral pneumonia, presents more gradually and is less severe, but bacterial is a whole lot worse. Pneumonia especially affects people who are chronically ill and terminally ill. A lot of people now are getting the COVID because it is a respiratory, and then coming down with the pneumonia, and then they're already bedridden because they don't have the energy to get up and get going. And then once you get in there, you'll get viral pneumonia. And then just because you've had so much antibiotics pumped into your body, you're gonna get the bacterial pneumonia. So it's a scary thing. I know we all hop on COVID right now because that's the only few letters that our industry knows and that we're so worried about. Um, some signs, some symptoms. We'll talk about rapid or labored breathing. They could have blue or gray lips, or even their fingernails just look like they're hypoxic. You're like, why are your fingers blue? I mean, don't like talk to them like that. Be like, I don't know, I would. Just be like, yo, you having trouble breathing? Hold my hand, baby. And you touch their hand, and their hands are like ice. We know we've seen those blue or gray lips when people are either super, super cold. You see those and you understand. They'll have, so with pneumonia, you can come across with fever, super dry skin, kind of looks like their skin's cracking a little bit. You'll have the skin turder, and what I mean by that is the skin is lacticity. It just decreases. It kind of dries them out. You'll have exertional dyspnea, which means when they try to get up and do something, they just can't, literally, like they can't get up and walk to the bathroom because they're out of breath. They're tired. They'll have a very productive cough, a lot of discomfort in their chest when they try to take a deep breath, or it hurts them. It's very painful. Headaches. You'll have some nausea. I haven't seen nausea and vomiting, but I know that's a big one. Musculoskeletal pain because everything hurts, and obviously weight loss because we know they're not getting up and moving because they're not getting a healthy diet. They probably haven't eaten in a couple of days just because they don't feel like it. Maybe I need to get pneumonia and lose a little bit of weight, but different story. They get confused very well because they're malnutritioned. They don't have the right intake, so let's just say the confusion's pretty well. And then when you go to listen to the auscultate their breath sounds, you may not hear it in a certain area. It depends if you're trying to listen to a certain lobe. Um, and I'll show you in a little while later where we're going to listen to our breath sounds. Um, but it's very hard. You want to check their temperature, determine if there is a temperature. You can do it by the temporal, you can under the arm. But remember, if you do it under the arm, what you got to add versus doing it orally. And just overall, it's just provide supplemental oxygen. Try your best to make them feel comfortable. If they're not comfortable, they're going to be painful. They're going to hurt. It's just over and over. Um, can anybody tell me what a different name for bursitis is while I take a drink of water? Somebody's got to know without Googling. I know somebody's Googling it. Hopefully, y'all will pipe in. Maybe there's a delay or something. But bursitis is also called, there you go, Corey. Good job. It's also called the whooping cough. It's an airborne bacteria that infections mostly affects younger than 6 years old. And it's like, oh. I mean, it's dirty. Like when you hear somebody, you're like, what was that? Like you're reaching for a gun. That's how bad it is. Again, this one's very contagious because it's in a droplet form. So when they cough, they're not covering their mouth. They're projecting the droplets, so be very cautious about that. Eye eye shields. I'm real big on wearing safety goggles. I'm not gonna wear the chemistry glasses that we all are required to have on our trucks, but patients will be feverish and exhibit a whoop sound after a coughing attack. Some coughing spells can last for more than just a minute, but during which the child may turn red or purple. It's because they're holding their breath. They're not able to breathe in and out. Some of the big things here, I guess y'all can see the last low one is to watch for dehydration. And suction is needed because again, it's hard for them to swallow. Their throat hurts. Um, Bursitis can also cause severe respiratory infection in adults. So this one can get it, and obviously y'all know why they can get it, just because we're going to take care of our children. If as a care provider, we're going to take care of kids faster and more hard and more in depth because they can't tell us what's wrong, but just know it's very, very contagious. So if an adult gets it, they're guaranteed to go to the hospital, and you're probably going to get super sick off of it. So be very careful about that. If you have a gown, wear a gown, and just if you recognize it early, protect yourself early. All right. So influenza type A, obviously we know it was a pandemic in 2009, an animal respiratory disease that has mutated to infect humans. Let's say in 2009, the H1N1 strand to influenza type became a pandemic, an outbreak that occurred on a global scale, much like what we're doing with right now. And then your symptoms. We've all had the fever, the flu at some time, so we all know it hurts. It sucks. Some of us have unfortunately had to work through it, push on with life. Um, and then you see there you may get pneumonia or dehydration. That's very common because, again, we don't think about hydration when we're so sick. We just don't want to touch this. Don't mess with me. Leave me alone. TB. I've dealt with TB personally. I've been exposed. I've been positive to the skin test. I had to take chest X-rays. I've taken the nasty pill that's ungodly huge, and you had to take it for 1 solid year. And just FYI, if you ever have to take the pill, you can't drink with it because it causes massive reactions. I can tell you personally that it sucks because I slipped off and drank with it one time. So it's a bacterial infection. TB is a bacterial infection that's most commonly caused in the lungs. It can also be found in almost any other organ, but obviously it's a respiratory issue. So it can remain inactive for years before producing any symptoms. Patients often complain of fever, coughing, fatigue, night sweats, and weight loss. I don't want the TB to get weight loss. I'm good. We can keep that. With severe infection, patients will experience shortness of breath, coughing, productive sputum, bloody sputum, and chest pain. Now, and you're going to see that more likely, like if somebody takes and they're coughing on, let's say, a tissue, and they're like, oh, look, it's pink or it's bloody. Automatically stop what you're doing. Go get gloves, eye protection, N95, and put something on the patient too. I don't care if they're coughing up tissues or their lungs and all that. You can keep that to yourself. So TB is also found with persons who abuse IV drugs or alcohol, or those who with HIV. And if you suspect your patient to have an active TB, like I said, we just went over that. Wear your gloves, your eye protection, and that's an N95 respirator at a minimum. We don't have positive pressure ones that we wear on the ambulance. I actually have worn one, the positive pressure one, when I was able to take care of a Ebola patient. It's very, very, very different from a SCBA in the fire service. It has different contraptions. It operates a little different. You don't get as claustrophobic if you've ever worn an SCBA to put these positive pressures on, but I mean, for TB, yes, you need to wear that. But an N95 respirator is fine. You can go from there, and it will also help. Anything helps to prevent yourself from getting contagious. If that's the case, don't be in their face. I'm not trying to say just sit at the head of the stretcher and with your hand over your mouth. No, just they're adults too. They know it. There's medicine out there for that. Hopefully everything works fine and you get over it and you can keep going. So acute pulmonary edema. Let's see. Sometimes the heart muscles cannot circulate blood properly. The left side of the heart cannot remove blood from the lungs as fast as the right side, so it diverts it. Where's it going to go? So the fluid builds up with the alveoli and the lung tissues. This accumulation of fluid is referred to as pulmonary edema. You can see it swelling in the cankle area. Usually results from CHF. Let's see. Sorry, stand by. Give me a second, y'all. All right. Patients usually experience dyspnea with rapid, shallow respiration. So it's, I can't, I breathe. So it's one of those, it's easier. Just, hey, look, you just sit there and breathe, and nod your head up or down, if not, right on this piece of paper. So in some severe cases, you may see a pink sputum that forms in the comb of the mouth, and it's frothy. It looks like cow spit. I've seen it twice in my life, and I was like, what is wrong with you? And then it dawns on me real fast, and I'm like, oh God, I just made a butt of myself, and I'm trying to take care of somebody. And I had never seen this, so I felt like an idiot. Most patients that have this have a long standing history of chronic congestive heart failure, and they can't keep it under control with medication. They can take medication to help with this, but a lot of times you start to see your worse, and people that just can't afford it, they're having financial problems, and that's why that they're in these conditions where now that they're calling you on a regular basis because they went to the hospital, they got their medicine filled there, and now they're out. So the hospital is their primary physician. So you got to think about that. Um, Not all patients with pulmonary edema have heart disease. Sometimes they just have a pump problem. Inhaling large amounts of smoke or toxic chemicals, traumatic injuries to the chest, and exposure to high altitudes can produce pulmonary pulmonary edema. If you change altitudes very fast, you can see it. Like prime example, I'm from Mississippi. A lot of Mississippi area is either at sea level or below sea level. When I went to Afghanistan, my first trip, I was over there for 4 months. The first 30 days, I was having trouble breathing. I noticed my fingers would swell. My ankles weren't so bad, but like I could tell that just something wasn't right, and my body was not acclimated to the altitude. So I learned that one myself, and I kind of treated myself. Uh, Hydrated myself a lot, started slowly working out a little bit more, and did more, stairs climbing than I did weightlifting because I had to try to get my lungs to work. And then finally, after I got used to it, it was nothing. Didn't happen to me again. But that's a big one that I know of. Um, Firefighters, that's the reason why we got to be very careful for your career. We know that uh, the old timey says they're nothing but smoke eaters. Well, that's true, but at the same time, as we need to be smart about it, that it's not smart to do overhaul without a self-contained SCBA on because of what all the carcinogens that's out there. At the same time, and some of these departments are all volunteers that they just don't have it. Uh, Rob, even just going to Denver for a week and NOLA will mess with you. Yeah, you're right. Uh, it's the change of altitude. You got to think about that. Just here in the States, it's going to mess some things up. So your body has got to get used to it. So that's a problem. Think about that. Um, I can tell you a lot of people have this and they don't realize what the problem is. When they sit down and they're like, why am I having trouble breathing? It's just the altitude. And we don't want to call it altitude sickness, but that is a part of it. I mean, everybody can revert. Understand what Rob's saying is it's just altitude sickness. Chase, even last night, it was I was in Minnesota and it was negative 20. Now, cause see, that's what's wrong with you. You in a part of the world that gets that cold. That just ain't cool. See, right now Mississippi's having trouble. We got like the ice freezing of a lifetime. I don't think it's been like this in 40 plus years in Mississippi, and like people have taken ATVs to the grocery store because they don't have the ability to get there. Our interstates are shut down, but negative 23, bro. That's on you. You can have that. I'm gonna let you do it. Travis was 19 in Leesville this morning, and everything's shut down. Yeah, so y'all get it. Pray for us southern folks that are not used to y'all's northern weather. Y'all can come get it anytime y'all want it. We're gonna do this last little slide right here, and then I'll. Did I skip it on my end? So acute PE, the heart muscles can't circulate blood properly. It's just not moving. The body. Did I? Hold on. I kind of got myself all messed up. All right, so I did do that one. All right, there we go. Sorry, my body's. I got two other things going on. All right, so right here we're talking about the alveoli. So now you understand. Here's a breakdown of it. This is what should normal be doing. So the fluid comes in and out. So now you start to see the edema is pushing out here, and that you notice the difference in the swelling of this tissue on the bottom down here. So this tissue swollen, and it's not going out the normal passages. You see here it's normal, in and out, lung capillaries. The fluid's pushed out through here and it weeps out and it's gone. So PE can be fast. I mean, acute pulmonary edema, problems with just, man, I feel for the people that have those, the swelling of the ankles, because I can tell you just my little bit in Afghanistan got me, and I hope not to have that again. See, thank you, Chase. I know you from Greene County, so that's good, folks. I actually got some family down that way. Guys, I need to step out for a second. Had somebody come into the door real quick. Let's take 10 minutes, and I will see you. What is that? 7:06. All right. See y'all in just a few minutes. Hey guys, I'm back. Everybody here? I don't guess I would really know if y'all weren't really here, but might as well figure that ask. All right, so let's get off of this wonderful slide and let's change something a little bit more important. Click, Chris. All right, so COPDs, chronic obstructive pulmonary disease, COPD. So it's a slow process of the dilation and disruption of the airway and alveoli. It's caused by chronic bronchial obstruction. So COPD is kind of like it's a big umbrella term that we use. It's to describe a lot of different lung diseases. So some of those may be emphysema. You have chronic bronchitis. It's an it's an ongoing irritation of the trachea and bronchiole that may be a result of a lung and airway damage from an infection of inhalation toxic gases. Like a lot of these are as a result, like your industrial accidents. You may have just a commercial, like let's say an AC guy may be filling up a refrigerant of a AC unit and it leaks or it gets out. And so now that may be some exposure, and later in life they get COPD. Tobacco smoke can create chronic bronchitis. So you'll have like your smoker's cough. Everybody knows what I'm talking about. You always know that one smoker that's got that. That's You can hear that cough a mile away and be like, "Smoker, there's a smoker in the room." It's always there. Unfortunately, offshore, they do allow smoking and any tobacco use really, but you always have that one person that smoked for 40 years and they've got the cough. Well, everybody now, you cough, sneeze, or you know, hiccup the wrong. Everybody's like, "Oh, what's wrong with this guy?" Let's see. So the tobacco smoke is a bronchioli irritant. Creates the chronic bronchitis. We know we talked about it's a very much ongoing irritation of the trachea. Um, that's what's caused the redness. A lot of times the people start off smoking small and then they go to like your heavy ones. I guess it's what Marlboro Reds is still kind of your heavy ones. I don't know. As you can tell, I don't smoke. Um, with bronchitis, you see a lot of mucus. It's a constantly produced and it's obstruction because we know we talked about that. It's a small airway and the alveoli, so it kind of gets in the wrong. They have all these issues there. Sorry, hang on. I was trying to read a message from Rob. Give me a second. All right. Hey, somebody don't let me forget. I need to pass on some information from Rob at the last when we get ready to hang up. So y'all give me an idea. Just remind me, please. Some airways are weakened as the lung protective device can be destroyed. So we talk about like some of the surfactant can go away in life. Um, you forget about those things. The surfactant is very important to keep our lung inflation. So your chronic oxygenation problems can also lead to the right heart failure and the fluid retention. So that's where we talked about the pulmonary edema, that you may see some pulmonary edema from COPD. A lot of times you can tell some people will always have their feet elevated. Sometimes you'll see them with their feet elevated a little bit higher than their heart because it keeps the fluid off of it. But then they have the lung that fills up with fluid, so it's a constant battle that they face. And pneumonia develops very easy in COPD patients. So repeated episodes of irritation and pneumonia cause the scarring in the lungs, and some dilation of the obstructed alveoli lead to COPD. It's you can't like you're let's say you constantly get pneumonia over your time in life, and it could relate to the development of COPD later on in life. Just because, like we just said, because it has all that scarring, the scar tissue's there, and the oxygenation is not building up right. There's multiple things that can cause that, but it's not saying that, oh my God, just because I got pneumonia once, I'm going to get COPD. That's not the case. A chronic pneumonia developer, I guess that's the way I want to put it, could see that in life. And COPD, they can get pneumonia from it. So it's one of those, it's just, you got to be careful when it comes down to it and treat aggressively as fast as we can. Did it change? No. All right. Now, emphysema is the most common type of COPD. Emphysema is the loss of the elastic material in the lungs as a result of chronic stretching of the alveoli. There's a pretty cool picture in just a second. We'll show you. Um, we talked about smoking can directly destroy the elasticity of the lungs. A lot of patients with COPD have elements of both chronic bronchitis and emphysema. Most patients with COPD have elements of chronic bronchitis and emphysema. They get because they have that trouble expelling the air from their lungs, and then they get the long expiratory phases, and then that's where the wheezing comes in. That's a lot of your chronic. They have a lot of sputum. That chronic cough. We talked about the smoker's cough already, so I'm gonna go back to the smoking. Um, because the smoke kind of fills the lung. Hold on, can y'all see that? All right, that picture is a little bit better. So this is normal. Where's my there it is. So that's normal. So your bronchiolitis there is cool. Then you have your alveoli. It's all kind of cool and pretty. Well, then now you get sick. Now it starts getting inflamed. So you'll see the mucus up here in the tree. So it's got to go somewhere because you want the air to exchange. Well, now it's starting to create these pockets. See the swelling down here? Hold on, let me turn on my cool little highlighter. Uh-oh, go back. We'll use this one. So you'll have all this trapped air and it starts, because down here in the lungs, it stretches it on the bottom side of this alveoli. But now that it's inflamed, you start to have issues. And then here we come as the obstructed. So now you see why you're going to have all this sputum. It's a buildup. You're going to have mucus constantly. Well, now it's starting to plug your alveoli. So it's taking place. So there's only certain places that oxygen can go. Like that's all trapped oxygen. See how swollen it is down here. And then look at the walls. If you will notice right here, the alveolar wall and the bronchial. See how thick it is on the normal side. Then you go all the way over here to this obstructed, and it's very very thin because it's stretching the material out and it's reducing the air. So if you have trapped air, you're just very thin. It's easy to pop. Travis says you can learn a lot about lung sounds from a COPD patient. Their lung sounds constantly change, especially in more. That is correct. Very, very correct. And if I remember, Travis, didn't you say that you had that in your family already? I'm trying to read back real quick. Yeah. So, and Travis is a good point. I mean, he can teach us a lot about that. He could probably go in depth. Unfortunately, I hate to say that, but you could teach us a lot more about some of the lung sounds, some of the signs and symptoms you're going to see. Travis, if you want to turn your mic on and pipe in, please feel free. I mean, I'm gonna give you the SME title for a subject matter expert on that one because you live with it. I mean, you know your daddy's got it. So, but that's where you're going to get your right in here on this picture. You see the mucus. The mucus needs to go out, and then they constantly cough because they feel like they're drowning because the fluid's in here. So it's a love-hate relationship on these right here. Fred line 2. Well, go. All right. So with COPD, patients sound like their lungs. But they're dry. I mean, so they sound like they're drowning. Patients with pulmonary edema may cause often by congestive heart failure, which often have the wet lung sound. So that's where your bronchi and your crackles come in. So different signs of the lung sounds. And patients with COPD will often have dry lung sounds and wheezing. So their wheezing kicks in, and it's just, oh, poor folks. So the wet lung sounds of pulmonary edema and the dry lung sounds of COPD can sometimes be confusing because you're like, is this wet? Is this dry? I don't really know. I'm confused. So don't just assume that all COPD patients that are having wheezing and they all have congestive heart failures have rails. You don't want to just note your lung sounds, see what you find, and have an idea. So that's one of those things that you can pull the nurse or the doctor to the side after the call and be like, hey, so can you guys help me out real quick? This is what I saw. This is what I heard. Am I right on this? Can you teach me real quick? Um, let me show me. I tell you what, can you mind showing me on this patient? I've kind of built a good rapport with him. Can we go in there and teach me what I need to listen for versus the different lung sounds? Am I hearing rhonchi, or am I hearing crackles, or is it upper lobe wheezing? because this is what I noted. It sounded like it was super wet. Let those nurses or doctors teach you, and respiratory techs are the best because they can do that. And it's really cool. They can show you so much when it comes down to it that unfortunately you have somebody that's sick. And a lot of times these patients are willing to let you learn, listen, and get better ideas by what they have because it's easier. Um, Patients with COPD, it's the wheezing is because of bronchioli construction, which it's packed in there. They present with shortness of breath, um, and they progressively get worse. They just you feel like you're going good, and they're just going down, and you're like, oh, I see my treatment. They're getting better from my treatment. No, no, they're not. They have reverse sounds to it. Um, they always have trouble breathing, and every time they get up and move, they just because remember we showed the picture. Their alveoli are full. They got these mucuses in there. Either they got trapped air in there, and it's very hard for them to move and get comfortable or even get breath when they move. Chronic coughing and thick sputum. So they're always going to have like a cup around or tissues in their pocket because no matter what, they cough, they're going to spit something out. I'll want it. You can keep that, sir, ma'am. Let me get you a little vomit bag, and you can, because I'm sure somebody's gonna want to see that when you get to the hospital, because they're gonna want to know is that tissue or lungs or does this patient present possibly have TB? Hang on, let me go turn that down real quick. I'm tired of hearing it myself. All right, so that's maybe something also is have your patient use a eminence bag instead of a just spitting in the tissue. So so think about that. They're usually long-term smokers, and they have the barrel chest appearance. Everybody knows what we're talking about. So you have these smokers that are smoked 40 years. You see them, and they've got that old barrel chest. They got that thick skin. You hear your medics talk about, man, trying to start an IV on that, it's like sticking in a wood. So y'all know these smokers we're talking about. Patients with congestive heart failure, they experience a fluid overload in the lung, so they feel like they're drowning. Um, a lot of your COPD patients will sleep in chairs, sleep in a 45-degree position because they can not lay down. They are drowning. They feel like anytime that they lay down flat, that they're gonna drown. Travis says, and about 75% of the time it will have a different culture. Oh yeah, and the sputum, yeah, it's gross. Um, so yeah, back to that. So you have these patients, they're going to be confused. They You got to kind of feel for them. You don't want to just quickly move past the patient. You want to treat them, give them the best opportunity, let them answer your questions because they'll get aggravated when you're trying to talk real fast and get the answer from them. Go slow, give them the respect of it. If you know they got COPD, bear with them. Get them that oxygen. Let them breathe. I'm telling you, O2 helps people out. I keep moving off. Travis, when CHF fluid overload, that is when you can definitely hear the crackles and wheezing on inhalation and exhalation. Correct. And they'll tell you it's a come and go thing. It's not like they're constantly always full of fluid. It's a come and go. It's a hit or miss. And then sometimes they have good days. They really do. And then the next time you know, you're like, what's wrong with them? They can't get up and go nowhere. It's a come and go. It's a progressive thing. And I'm sorry if y'all keep seeing my mouse whatever kind of I changed back between who all's here and the question, so that's the reason why you see my mouse in the corner. Um, where's it at? There we go. All right. So asthma, hay fever, and anaphylaxis. We've all dealt with this at some point, maybe our personal lives. We've had this as a patient or anything like that. Um, So asthma, hay fever, and anaphylaxis result from allergic reaction or inhaled, ingested, or injected substance. In some cases, there is no inflammable allergen that triggers the immune system, it just goes. Um, these the hay fever, we've all heard of those people, and we used to make fun of them when I was younger. I was like, man, you ain't been around no hay. That's just because I didn't know. Um, the asthma, sometimes that can be born that way. Sometimes they can just get it as they're growing older. You and then you get it the older you get, your body just getting the way it is. Um, I'm clicking on the wrong screen here. So asthma is an acute a spasm of the airway, smaller airway. So if you'll see right here, this is where it starts to. This is where your asthma comes in, on the right hand one. So here you go. So it's an acute spasm of the bronchiole associated with excess mucus production and swelling of the mucous lining in the respiratory passage. So right here is normal. Taking a deep breath, we feel great. We moving right along. Well, then they start these asthma patients. That's the reason why they feel like they're breathing through a straw. They Sometimes it's easier, and that's how they explain it. As I can't ever get my breath, I always feel like I'm having trouble breathing. It's because they're asthmatic. You want to treat those aggressively, and over time that they may just be. Oh, well, I was supposed to talk about it. So it can be from children, um, and believe it or not, 25 million Americans have asthma. I mean, I'm sure that number is probably a little bit higher. I mean, I am going off some information that may be dated a little bit, but it affects all ages of life. I mean, we talk about from children to, I mean, my mama had a small dose of it when she was still around. So that was just because it came upon. It wasn't one of those things she was born with. Produces a characteristic wheezing caused by, which showed you just a second ago. Reason wheezing is indicated um, of a particular lower airway obstruction. Wheezing may be loud that you can hear without a stethoscope. You may have to auscultate it. You may have to listen for it. So in other cases, the airways are so blocked that no air is moving in and out. That is a complete airway obstruction. That's when your pucker factor happens, and you're like, um. So, an acute asthma attack may be caused by an allergen specific to foods or some other allergen. Attacks may be caused by severe emotional distress. So I think we've hit on that before. Some exercise, respiratory infections. Its most severe form and allergic reactions can produce anaphylaxis. We know about that because everybody's learned anaphylaxis. We got to hurry up and get them epi, but we may not understand why it happened. We talked about that one. So it may result in respiratory distress severe enough to lead to a coma or death, that they just go into respiratory arrest. Then that's the worst part of our jobs. It sucks. Most patients with asthma are familiar with their symptoms, and they know when an attack is coming along. The best thing I can tell you, I had a little kid that had diabetes, man. He was probably 8, and I got called to the school, one of our local schools, when I was still on the ambulance a lot, and he taught me so much. I just sat down at the table and listen. I let fire go back in service. I told the teacher what I was trying to do, build rapport. Had to wait on mom anyway. But man, that kid taught me so much. I felt like I was ready to conquer the world after talking to this little 8-year-old. Taught me about diabetes. So listen to these people when they start to tell you they know that it's coming. I'm starting to have a lot of trouble breathing. I feel like my asthma attack's kicking in. What do you normally do? I mean, the old wives' tales, take them to the freezer and put their head in the freezer. Right now, in the southern part of the U.S., just take them outside. It's super cold anyway, so that'll help them. Yes, that is a wives' tale. Yes, it does work. So I'm not going to tell you that to don't do it because it does work. So it's not all regulated in treatment. Sometimes you're going to have to figure out how you write that in your report. But good luck. That's on you because I've always been very straight up on my reports, no matter if it's right or wrong. I have a tendency to stay on the right thing. Um, Sorry, my son wants to start asking questions, and I'm teaching. He knows it. So hay fever causes cold-like symptoms. Um, Runny nose, sore throat, diarrhea. No, I'm just kidding. So it's runny nose, sinus congestion, sinus pressure. It's the same thing we see all the time. So some of the allergens we see right there include pollen, dust mites, pet dander. A lot of these people I've seen don't have pets when they know that they had that. Um, so that's because that's some of the things that trigger them. They um, Anaphylactic reaction can produce severe airway swelling. They'll have total obstruction as possible, which is they shut down, they lock up, and you're going to treat that with epi, oxygen, and antihistamines, or several other antihistamines that we can carry. Depends on what service you're with. I could go on what they're out there for us, but um, patients with hay fever tend to be more atopic, meaning they're more likely to have another allergy. So there's several different allergies, and that may be just part of it. Anaphylactic reactions are severe reactions characterized by severe airway swelling and the dilation of the blood vessels, and it's similar signs and symptoms of asthma. The airway can swell so much that we talked about they shut down, they lock up. Patients may not be aware of their sensitivity to certain substances, especially in your younger kids. We talked about what is that, 4 to 17, 5 to 17, that they say that some of that's around. And oxygen and antihistamines are the best to get them opened. So they need a advanced life support as fast as they can get there. And your agency may already dispatch them with respiratory issues, or it may turn into, you know, trouble breathing, come out as a panic attack, and then their asthma kicks in. So the faster you realize that, and you do your patient assessment, and you find out their history that they have anaphylaxis, get your ALS provider there fast. Pneumothorax is the accumulation of air in the pleural space. It's not supposed to be there. Most of the time, 99% of the time, it's caused by a trauma. And it may be caused by a medical condition, and that's where you get the spontaneous pneumothorax because it's just, I had exactly what I was going to tell you in my head, guys, and I'm sorry, I just went blue. So, and it's just one of those, it's rare, it's uncommon that they get that spontaneous pneumo, but you got to fix it. You got to know what you're looking for. You got to listen, pay attention to them. If they have really weak lungs, they're going to get that pneumo. Let's see, this slide tells you a little bit more. So the pleural space is out here on top of the lungs. That's the place between your lungs and your chest cavity. That's the pleural space right here. Yeah, and let's say there's a little bitty hole right there, or it's an infection, or now the air, you may have trauma that's busted that little spot right there, and now the air is filling up on the outside. Um, you have the collapsed lung here because they have the hole. Your diaphragm, man, know what you're looking for, pay attention to them. Uh, it can be severe. It could be mild depending on what's going on. Spontaneous pneumos occurs in patients with certain lung infections or young people when they're born that way. They may automatically be born. They may have to have a lung transplant that they get those pretty common. I know a nurse in PICU that she's decompressed a child in one 12-hour rotation 46 times that they had to go from to the chest to midline and all that. So it was a lot. So they ended up putting a tube in for the baby, but she caught it pretty quick and they couldn't get the surgery situated fast enough. Um, Tall, thin males are at a higher risk. A patient with a spontaneous pneumo becomes dyspnea and might complain of chest pains. It's a sharp stabbing pain, and it's only on one side. That it's always worse when they take in deep breaths or they do certain movements. If they stretch out further, like say if they do like lean back in their chair and they're trying to stretch, well, that's creating more space in the chest. So it's going to be a lot worse, more pain. They want to try to keep the small area and don't take deep breaths, and because it hurts. They want to keep that lung inflated. Um, you can sometimes tell that the breath sounds are absent or they're decreased on that side if you do auscultation very well, and you pay attention to your patient that their lung sounds are disappearing. You may hear it fine perfectly in the beginning, but then you may not later on in your assessment. If their respiratory impression gets worse and you're staying on top of it, then the better off you are because now you're realizing, hey, 10 minutes ago I heard long sounds and now I don't. So what's going on here? So we'll talk about pleural effusion. Its pleural effusion is a collection of fluids on the outside of the lung. It compresses the lung and causes dyspnea because now the lung and the fluids fighting for space out there. Basically, they're trying to say who's bigger and has more range, but unfortunately, it's gonna kind of fill to the fluid, so that's a problem you see. Um, it can be caused by irritation, infection, congestive heart failure, cancer can cause it, and people feel better when they're sitting straight up. You know, a lot of times you have people like, oh, I'm having trouble breathing, so I lay them back on their back. Well, that may not be the best thing. Let's set them up, get them to lean against something, and then you can kind of help ease that pain away. Not saying that you don't want to withhold the oxygen, but it may help them breathe on their own. Getting that comfortability in them. So obstructions of the airway. Uh, a patient with dyspnea may have a mechanical obstruction. You want to jump on that pretty quick. Don't wait. Remember, there's really only one way for oxygen to go in the body that's natural, and that's in the face. If it goes in and out elsewhere, it's not supposed to happen. So in a semi-conscious and unconscious patient, the obstruction may be caused by aspiration of vomit or tongue blocking the airway. We all know, we've always heard about the tongue and aspiration. Unfortunately, in my career, I've been blessed in education. I've learned a lot. I've worked a lot of cardiac arrest. I've never truly seen a tongue so big that it's caused an airway obstruction. Now, I have seen them block it, and you do a head tilt chin left, and it clears it pretty easy just because the relaxation of the tongue. So, but if I guaranteed you, if somebody's going to code, they're going to eat greens and they're going to fall out in the bathroom. It's always the worst place it's going to happen. But right there it says a patient just eating before dyspnea may consider a foreign body obstruction, and that's where your aspiration may come from, because the patient's like, man, I don't feel so good. I'm trying to go to the bathroom. Well, when they do faint, they pass out or something else from an obstruction. They do vomit a little bit. Maybe that fixed the problem when they hit the floor, but now they swallowed the vomit, and that's where it's created the problem because we can't see it. We can only just clear out what we can see. Um, So here's some pictures of food in the airway. Where's my mouse? Right there. So that it's blocking the air passage. And then the tongue, you see how it's just dropped back and set down. That's more of what you see. Yes, you can still get here. Um, you will hear some of the like the snoring sound when that's kind of like, not saying all snoring is caused by that, but um, you won't have a full, or my mercy, so you won't, they won't be breathing very regular when that happens. You may hear agonal respirations, and as y'all know, agonal respirations is not supportive of life, so we have to be careful there. We need to treat, act, jump on that pretty fast, and make sure we can clear that airway because it's important. Going PEs, pulmonary embolisms. So is an embolism is anything in the circulatory system that moves from from its point of origin to a distant site and lodges there. Obstruction subsequently blood flow in that area. So circulation can be cut off completely or partial because the PE can fill the area or it can just move back and forth. Um, an embia Oh, nope, that's not what I was looking for. So there can also be foreign bodies that can either enter the circulation, such as a bubble of air. That's the reason why in the hospital you see that people, especially in the EMS world too, as we go to give shots or an injection, you always want to clear the air out. Now, understand, not just a little bit, uh, I don't even want to say, you got to have a full syringe, like 3 cc to a 5 cc syringe full of air to create a PE, but it can happen. And we always want to make sure that all the tubing line is completely filled throughout of water. We want to put the IV solution completely. Don't want to leave no air in there. When it runs out, we want to occlude it, want to close that off. It's just to prevent any negligence of the EMS field. So if that's one of those things that you see, maybe the medic's got his eyes off talking to a nurse about a report and the bag gets low, just cut it off. I would rather fluid be sitting there than the empty bag and draining completely out and negligence and my fault of the field. A PE is a blood clot that circulates through throughout the venous system, and it may be a result of the lining of the vessels. You talk about damage, um, what is it, slow blood flow, or a lower extremity often results in long-term bed rest. That's the reason why they put those nice little socks and they compress your feet, they rub your ankles. No, they're really annoying. I'm just trying to make it sound nice. So the reason why they want to do that is increase the blood flow to keep you from getting a PE. It doesn't always work, but it's very helpful to have those socks that fill with air and they're on a timer. And so when they can, the quicker they can get you up and moving after a procedure, a surgery, hospital stay, the better off it is for you and your survival of less of getting a PE. Signs and symptoms: you'll have dyspnea, tachycardia, tachypnea, varying degrees of hypoxia, cyanosis, chest pain, uh, with a large enough embolism. A complete obstruction of the output of the blood from the right side of the heart can result in sudden death. So, if the PE gets in the right spot, you can die of an instant cardiac arrest. I have taken care of one gentleman at a gas station in my life that turned around and he was talking to the group, talking to the place, and they were trying to get 911 called fast enough for him. And I literally got out of the ambulance and walked up to the door, and literally he fell back and died right there on the spot. There was nothing I can do for him because it just happened, and it didn't matter how long I did CPR, how aggressive it was not happening. Tapnea, Travis, is what you're asking for. Is so it's rapid breathing. So I kind of resort back to the old, some of the old movies that. Anyway, I'll show my age on that. So it's the normal breathing rate for an average adult is 12 to 20 minutes. So you're gonna, and then for children, the number of breaths can be a little bit higher. We're going to talk into like 16 to 22 times. Just depends on their breaths, but it's fast respiration. So it's kind of like because they can't ever catch their breath because there's a PE that's blocking it or respiratory disease. So it's an infection or anything like that can be bothering them. Here's another, I call it also hyperventilation, but under technia, it's more common than hyperventilation. We see what we think about hyperventilation is like a panic attack. We don't really want to make sure. I'm trying to make sure everybody's muted. So hyperventilation, we're going to define that as overbreathing to the point the level of the arterial carbon dioxide falls below normal. So sometimes people that can breathe super, super fast will pass out. Well, yes, you can only get certain people's respiratory rate, get them to calm down so much. But unfortunately, and it's kind of ugly, I've always said that once they get to a certain point, they can't breathe. No, I mean, they're going to pass out and their brains, oh, sorry, y'all, I hit the wrong button. And their brain's going to reset and they'll start breathing fine. So you may see hyperventilation and it's a life-threatening illness because that may be the last few signs that you see in the body that they got better, now they're starting to degrade. And then it says the body may be trying to compensate for acidosis, and that right there is a buildup of acid in the body. They're trying to off-gas it, so that's maybe why you see it in the last stages. Some other hyperventilations, it can be like alkalosis. We just could be a base, so that's the reason why it's very hard to just say, oh, they're having a panic attack. Well, yes, that can cause it, but at the same time as you're trying to off gas the over acid, or you may just not be doing good. There may be some other issues related to it. It says the decision whether hyperventilation is being caused by a life-threatening illness or a panic attack should not be made outside the hospital. Treat it for what it is. Go for there. You want to tell your patient to slow their breathing down, take slow, deep breaths. If that just doesn't work, get them supplemental oxygen and take them to the hospital. We want to try as much as we can to just calm them down and see how that works. But a lot of times those panic attacks, it's just not going to work. They're going to do what they want to do. So we've all seen this. The pesticides, well, cleaning solutions, certain like hydrogen peroxide and some, or I'll tell you, pine sol and chlorine or Clorox. Even though it smells really good when you clean your bathroom, that can create some very, very dangerous fumes. We talked pesticides, cleaning solutions, chemicals, chlorine, and other gases may be accidentally released at an industrial site and inhaled by employees. So many industrial sites have their own medical, fire, or hazmat teams. I'll speak specifically. I know like BP, their onshore plant down in Baton Rouge, they have a very large hazmat crew, and they have a couple of their own safety medics there. Very good job, but it's very, very dangerous. We talk about carbon monoxide. Everybody knows we preach about that. It's odorless, colorless. It's highly, highly poisonous. They put don't ever put yourself at risk to try to get somebody. Um, if it's it could be by suicide. Who knows what's happened on the inside of the car? Make sure you have proper SCBAs, the fire services there, ventilate it very well before you try to go up, and we try to just do the best we can for people. But man, it's horrible sometimes with this carbon monoxide. Um, Carbon monoxide we know is produced by some of the fuel burning household material appliances. It presents in smoke. People who have carbon monoxide poisoning complain of a flu-like symptoms and even dyspnea. High flow oxygen may be the best thing that's been treated for them if they're conscious. Patients who are unconscious or have altered LOCs, they may need full airway control. You may have to put that King or that Combi, or ALS may put that ET tube in there. So think about those. If you know that you're going for, a CO2 exposure, same thing can happen in firefighters. Give them the oxygen. Already have the mask ready. I'm real big on rehab for fire service. If it's set up correctly, everybody who comes out of the house, whatever that department's protocols are, 1, 2 bottles, has to go see EMS and get a workup before they're cleared to go back to fight more fire. It's for their safety. As they're sitting there and I'm going through them, I give them some oxygen, and when I'm done, I take it off of them, let them sit there for a minute. I check their pulse ox to see what it is without oxygen on. You want to get that CO2 burn out, all those carcinogens. You try to push clean air through them, and so they can off gas the bad stuff. That's just something I've gotten the habit of with all these years, just trying to help them out the best that we can. So we talk about scene size up, man. That's in every single chapter we go over. You think it's important, you'll kind of get it. So we know what our standard PPE is nowadays. We tell our people offshore PPE is offshore helmet, eyes, gloves, ear protection, and a mask. So even on an ambulance, your protection should be eyes, gloves, and a mask, because that's the standard that we push now. We can only lead by example, especially if you're on an ambulance. You may be those. I think masks are horrible. I don't like them. That's okay. That's a personal decision. But just remember, when you're on an EMS, you represent the entirety of the whole industry. So try to lead from the front. Try to prevent the exposure, especially even if you're sick and you don't know it. You don't want to give it to somebody else. Consider the possibility of an infectious disease or toxic substances when you go on scene. Is there multiple people? We don't know. Um, and you want to consider the possibility of airborne hazardous material release. Always set up uphill, upwind. Protect yourself. Make sure you ask questions before you go in there. If you don't know, get with somebody, maybe the family member, bystanders, the scene commander, fire, police. Ask them what's going on. Hey, tell me what I need. I need some information before I risk my life to go in there and try to treat somebody. Um, Go over primary assessments. You identify the life-threatening issues, and it's probably with the ABCs. If there's any problems with the ABCs, fix it. If any major problem is identified, treat the immediately. Don't stop. Don't go past go. Don't collect $200. Fix your ABCs. You want to form your general impression. Form an overall general impression of the patient's level of distress. You want to note their age. Is the patient calm or anxious? Use the AFPU scale to check responsiveness, and even ask them, hey, what'd you call me here for? Well, somebody already told you I can't breathe. Well, you're talking fine. I'm just trying to figure out what's going on at this present moment. What am I here for? What can I help you with tonight? Airway and breathing, you can assess that from across the room. You don't necessarily have to put your hands on them to check that, because if you can say, hey, how you doing? And they respond to you, you know their ABCs are good to go. Look for their rate, rhythm, and quality. Is it enough rate, rhythm, and quality to support life? If it's not, fix it. If there's any questions about airway patency, it must be opened immediately. Head tilt, chin lift, just use a jaw thrust. Evaluate whether the patient's breathing adequate or not, and let's fix it. We talked about the rate and rhythm. Ask yourself some of the following questions. Here you go. Is there air going in, and does the chest rise and fall with each breath? Well, if not, you can fix that. And if the adequate rate for the patient's age, know your respiratory rates for your age, and that goes from infants to pediatrics to adults. Know your rates because it will help you in assessing your patient. Oh, give me 1 second. All right, so we talked about where to auscultate from. So here's the areas that you want to auscultate. Check the breathing sounds on the right and left sides. Listen over the bare chest. Don't listen over clothing. I know sometimes it's cold. That's okay. Warm up the bezel of your stethoscope and place it against the chest. Sometimes if it's cold, you'll be able to check their sensitivity. Now, obviously, I don't want to strip them out there in the middle of the cold negative 32 degrees right now, but I want to listen to their breath sounds. I want to put my stethoscope underneath their shirt and be respectful about it. Drop the bezel down there, maybe hold it from the outside, but remember, we're trying to be respectful. So you want to determine if the breath sounds are normal, do they have bronchial breath sounds, are they decreased, are they even there? I mean, I need to know that. Check for breath sounds on the right and left chest and compare them. Do I hear breath sounds? Do I not hear breath sounds? I hear them in the top, not the bottom. So you want to listen to them in a full respiratory cycle, in and out, in and out. I always do 2 breaths per area. That's a me thing. I have to have things evenly. So any abnormal breath sounds you may hear, like it shows right there, wheezing, rails, bronchi, or stridor, mark those. If it's snoring, maybe they not awake or maybe they're unconscious. Note those. Can you fix that? Can I provide high flow O2? Is it going to fix any of this? Well, if I don't hear breath sounds and all I do is do a jaw thrust or head tilt chin lift and supply oxygen, maybe that's all they needed. And you jump started their body in the right direction. Check for your circulation. Evaluate for shock and bleeding. Man, assess the capillary refills in infants and children. Squeeze their little fingers and see what they are. I also, depending on the outside temperature, I also squeeze the toes. I need to know if they're sorry. I need to know if they have good circulation. Are they getting good blood flow to the feet? You want to reassess and identify any life threats your patients may have. If you fix it and you go back to it, is it working what I did or is it not? Any problems with the ABCs? Do you have poor initial general impression? Do they just look like crap? Are they responsive or are they unresponsive? So, and then you look for potential hyperfusion or shock. Can I fix any of that? Do I need to cover them? Do I need to elevate their feet, put them in Trendelenburg position? Do they have chest pain? What about low blood pressure? Well, is there any of that you can fix? Yes, you can fix. That's all in your assessment. You can do stuff about that. If they have severe bleeding, stop it. Put your gloved hand over it, and while you grab some tool, while you grab a tourniquet or ABD pads, you can stop that. Then you make your transport decision. Are they critical? Are they non-critical? So if that's like we've all said, stay and play or load and go. That's really the basics of that transport decision right there. I don't know if there's any way other we can describe that. So on your history, we've beat this kind of into a, I say beat it, beat it, beat it. But when it comes to registry, you need to make sure you pay attention and you learn this how to take a history because it's a lot of your assessments are doing a good history. Maybe you didn't ask certain questions and the evaluator's not going to tell you. So you look for their chief complaint. Objective and subjective observations are important because we're not there to form opinions. We're there to fix them. Uh, Find out what the patient has done for the breathing problem. What were you doing prior to me getting here? Some different respiratory complaints offer different clues and different challenges. Try to determine what is the patient's baseline. Ask somebody, how are they normally? If this is normally, well then they not right. They crazy. No, I'm just kidding. So with patients in respiratory distress, a sample history can be collected from bystanders, family, like I just said. Ask them what is the deal. Ask some of the following questions. What is the patient's general state of health? Has the patient had any childhood or adult diseases? Now, I'm sure that bystanders probably not going to know that. Maybe a coworker may not. And they may not have told anybody because they're embarrassed when it comes down to like an adult disease. Have there been any recent surgical procedures or hospitalizations? Because you can think about, oh, if they've been in hospital and they're a week and now they're back and maybe they have a PE, that's what's causing the respiratory issues. 2 seconds, guys. Um, and has there been any traumatic injury lately? What's the deal? Been involved in a wreck? That's the big one. Have you been involved in any kind of head-on collision or any motor vehicle accident lately? Sample history, signs, allergies, medications, past pertinent history, last oral intake, and everything else. How I keep going it every single time. Here's some other little acronyms that help. OPQRST. Uh, Again, we want to check those. I'm trying to see if there's anything else in the notes real quick. You can modify your OPQRST. Depends on gathering about their. And when you modify it, if they're having breathing problems, you don't want to sit there and try to ask every single one of these. What's the onset? How long has it been going? What's the qual? Just modify it to get your answer. What makes the breathing difficulty better or worse? Well, that is anything that you do make it better or worse. If they nod their head yes, then you know that there's something. Or they're like, no, it just came on. I don't know. Uh, and then you say, how much of a problem is the patient having? That's their severity. If you're there, it's an emergency to them. So remember, figure out what you got to do. PACE assessment, specific for patients with dyspnea. Here's the breaks down: progressive, associated chest pain, sputum, talking, tiredness, and exercise tolerance. I've never used that one, but that is very, very good information. Uh, I kind of like that. It's kind of neat. So you may want to, if you need to write those down, those are pretty cool. Your sample, OPQRST, and your PACE assessment. If any type of person that has dyspnea, shortness of breath, those will help you get a baseline down. Secondary assessment, we know that that's more in depth. We want to try to keep, this may be done on scene. It could be done on the way to the hospital. It just depends on what's going on with them. Only proceed with a secondary assessment if the life threats have been addressed and treated. If you're still having trouble containing that, or getting that, sorry, if you need to apply another tourniquet, maybe that bleeding is still going on, don't go into your secondary assessment until you've got your primary taken care of and it's done. Keep an open mind as you gather and complete a history as possible. Um, and when you're performing that secondary assessment, go depth. Is the respiratory system? What about the cardiovascular system? What's up with their skin? Just recheck their blood pressure. Are they able to make educated decisions? That's when we ask about their neurologic. Do they know who the current president is? Do they know what time of year it is? Do they know who the pretty lady sitting across from it is? If you're in their house, it may be their wife. Um, so, and right here at the bottom, proceed only after identifying life threats. I already said that. So don't go into your secondary assessment until you have addressed everything that you can on the primary. I am watching the clock. We're going to go until straight up 8 o'clock. So looking for signs of COPD. Is the patient older than 50 years of age? Do they have a history of lung problems? Are most always long-term active or former cigarette smokers? Do they complain of chest tightness and constant fatigue? I'm always tired and I can't ever catch my breath. I've heard that multiple times. Do they have that barrel chest, the leather skin? Are they constantly using all their accessory muscles to breathe? Are they bent over in the tripod position? When you walk in the front door and you see the chair, and they have multiple pillows sitting around the chair, and everything that they need to function day-to-day basis is right there beside them. That's because they get super tired and they have to get up and move. So they don't want to move. They only want to move when they really have to. If you're able to listen to them, do they exhibit any abnormal breath sounds? If you're able to listen to them, do you hear anything? Do you hear those weird sounds? They're like, this ain't normal from breathing. I don't know what's wrong. So in your reassessment, let's reassess all your things that you found in the beginning. Is this fixed? Has anything changed? Has their blood pressure gone down or has it gotten worse? I need to know that. You want to confirm any of the interventions you did and what's the patient's status. Did I give them oxygen? Did they improve? Did they get worse? Those are some of the things you want to know. Some of your interventions right there: oxygen, non-rebreather, positive pressure ventilations, airway management. As the positioning in the high Fowler's position is a choice. Some patients want to be set 90 degrees straight up because they got the fluid. They don't want to lay flat. They don't want to lean back because they can't. It hurts. Or sitting on that stretcher is just they need to sit up. They need to lean over. Well, you can't, sir. We're moving down the road. You got to stay buckled up. That's a fight you're going to have on your hands because they feel like they're drowning. And are you having to assist with any respiratory medicines like albuterol, any sort of breathing treatments like that they have? That are you having to help with them? Are you having to suction the airway because there's so much mucus? Is there so much sputum? Then maybe you're putting them on CPAP. If you're able to transport CPAP in your area, that's a really big issue. CPAP helps clear those fluids, and it's so much pressure, it's pushing it out. It's opening up that alveoli and the bronchioli that's sitting there that's full. We talked about that. Communicate everything you can that you found in your assessment, your primary assessment, your secondary, and then reassessment. If you don't give any of that information to the hospital, you have hurt that patient because now they're going to have to go back over every single thing that you did. Not saying that they won't, but they got to do it automatically because they don't have nothing to go off of. All right, folks, I show straight up 8 o'clock on my clock. I'll give you 10 minutes. I know y'all are tired of hearing me, and I'm going to drink something. My throat's dry. I'll see y'all at 10 after. All right. Hang on. Let me catch up on the chat. Mary asks, is there any way you can type the question if one is asked? Mic is not working. Sorry, speakers. Uh, we're on a break. Back in 4 minutes. All right. So yeah, I'll be happy to do that for you, Mary. So going over the reassessment, we talked about that one. Let me get to where I can click on it again. All right. So if you're administering supplemental oxygen, some patients may need CPAP or a bag valve mask. If a patient complains of difficulty breathing, you should administer supplemental oxygen immediately. Don't withhold that. Take great care in monitoring the respirations. Note those, write them down, take notes. Reevaluate respirations and the patient's response to oxygen at least every 5 minutes, because if you that's providing and doing a life-saving minute. So instead of doing your 5 to 10 minute checks, if you give them oxygen and you know they're in respiratory distress, automatically reassess them every 5 minutes. You don't want to say that they're critical, but respiratory can be a critical thing. Never withhold oxygen from a COPD patient. Just limit the dosage. You may not be wanting to give them 15 liters, but you can give them, 2 to 4 liters by nasal cannula if that's something they can require. If they're having trouble breathing, maybe you can do blow-bys with maybe a BVM can do that, but don't put it on their face. Let them hold it. If the patient has a meter dose inhaler or the asthma inhaler, let them use it. Consult med control, make them sure the medicated is indicated. Make sure that if that helps fix the problem, let's reach out and ask questions. It's always better to ask questions than when you go back and say, well, I didn't do it, please forgive me. Let's always ask, make sure we're on the good go. Travis, we start low with steady and end up at levels. If we up them too fast, he'll get oxygen headed. Yeah, and it's also considered like an oxygen high. Sometimes he may get a little loopy or just kind of asking weird questions. It's like an overdose. You gotta work that way up there. So good point. I'm glad you pointed that out, Travis. Some of the contraindications is a patient unable to uh, coordinate inhalation. Maybe they're a little lethargic, they don't know what's going on. The inhaler is not the patient's inhaler just because they have a meter dose inhaler, because maybe the husband and wife are on the same exact medication and she hands you hers and not his. Yeah, I really need to see his. I understand that he may be out, but here's why. Call and ask. Permission is not obtained from med control. Don't do it. You ready? Here you go. Don't do it. I don't know if y'all can see all that moving around. If you don't get med control approval, don't do it. If your local protocol doesn't allow you to do a certain thing, call somebody who can. If you get the maximum prescribed dose prior to arrival, hold off on that medication. Still call, give that to the doctor, let them know, let them make that decision. And then again, if the medication is expired, even if it's just by 30, 60 days. I've seen somebody use a meter inhaler that was a year and a half old, and I was like, no, cuz let's not do that. We move on to something else, maybe a little bit better. There are other contraindications specific to certain medicines. So if they're getting one, hold on. Sorry about that. If they're getting a certain medication and they go to get another one, and you know that there may be some contraindication, call and ask, and let's get specifics. We don't want to harm the patient. We want to make them feel better, especially during respiratory. So most medications are used to relax the muscles around the air passage. So we call them like bronchial. Well, where did it go? So, dilators, we want to make sure it's a bronchial dilator, not a constrictor. We want to open their airway, make sure that they have good passages to breathe from, and we want to do the best that we can. So some of your common side effects for some of these medicines that we give, they will increase the pulse rate. They'll get a little nervous. You may see some muscle tremors in the fingers. They start having panic attacks that last for X amount of number of minutes and they're not controlling their respiratory rate, you may start to see their fingers draw up. Their arms will kind of start getting tight and they're starting to freak out. And you're like, I'm trying to tell you, slow your breathing down. And then they're going to go into decorticate posture. It will kind of freak you out if you've never seen that before. And just try to give them the oxygen, try to help them calm down. If it doesn't calm down, that's when you need to, figure out about transportation. The faster you can get them there. Some upper treatments of specific conditions. If you have the availability of humidified oxygen, go ahead and give that. Don't attempt to suction the airway or place an OPA with a patient that's got epiglottitis or epiglottis, because any little bit will make it swell. You don't want to swell it. Let them get to the hospital. Let them do the advanced airway. Where a respiratory can do it if they need to knock this patient out. Let the hospital do that pretty fast. And where it says transport promptly means basically you want to hurry up and go. Don't slow down. You don't want to collect $200 either. You want to get going. So acute pulmonary edema, always give them oxygen. Don't worry about it. If they need some suction, okay, cool. Their position of comfort is the most thing, because it helps their breathing. If you lay them back, they start getting stressed out because they don't feel like they can breathe. You're going to notice a change in the respiratory rate. Some unconscious patients may require full ventilation support, so you may have to put that adjunct in. You may have to bag them. If you're in the back of a unit and you have an ALS provider there and they do put that advanced airway in, they may put them on a ventilator. It just depends. But most of the time, if you can just get them in the right position and they sit comfortable and it's not too serious, you can hopefully calm that down. Provide CPAP if that's allowance in your basic protocols. If not, you may have to get an advanced provider there to place that on and transport them promptly to the ED, ER, whichever one you want to call it. All right. So COPDs you want to assist them with that inhaler. Watch for side effects because they may try to hit that inhaler a couple of times to help open. Their family may be like, oh, they got to hit it like 5 or 6 times. Well, that's not what the instructions tell you to do, because it's not going to work that way. And again, put them in a great position, whatever is the best for them, and transport promptly. Y'all kind of get the idea of this. Everything is transport promptly. That kind of helps us out there. So when you take care of acute pulmonary edema, give them oxygen. Same thing. Same exact thing. Oh, sorry. I'm looking at the wrong one. So we're on asthma. I don't know where I'm at. All right. So be prepared to suction if needed. They may feel like they're not able to swallow. You want to assist them with that inhaler because that's important. If they've got that inhaler on them, let's get it. Let's use it. Let's make it work. If you have to provide an aggressive airway management, do it quickly. Don't hesitate that, because all you're going to do is delay patient care. And then it says a prolonged asthma attack that is unrevealed may progress into emergency known as status asthmaticus. Give oxygen promptly and transport. That is what I can tell you on any type of asthma attack. If you know what's happening and you can't fix it, their medicine's not working, as a basic, there's nothing that you can do. Let's give them some oxygen and get their butts to the hospital. That's the best that we can do. We talked about hay fever. A lot of the time, you're not going to need ALS care or BLS care. They may just be using you as basically an Uber or a taxi because they don't have means to get there, or they may just be a single person. They can't drive themselves because they're scared. So they may just be using you that. For anaphylaxis, if you're able to remove them, let's say it's peanuts, flowers, or whatever else, and they've already given themselves the epi, remove them from that environment. I don't want to say secure the airway, but you want to make sure you protect it. Talk to them. Talk to them quickly. Hey, look, I need you to talk to me. What's going on? I know you just took your epi shot, but tell me how long you've been having this issue. Come up with something to talk about. It's for the betterment of you. So get these informations out there and make them talk to you, because that's the way that you can also assess the airway. Um, if they need oxygen, provide it. We talked about spontaneous pneumothoraxes. We know that that can happen out of the middle of nowhere. Uh, Transport promptly. The pleural effusion, removal of fluid, you can't do. You don't have the ability to suck the fluid out of their lungs. We know that. Always give oxygen, and again, provide transportation. Um, when we talk about obstruction of the airway, it's either going to go a full, complete, or be a partial. Um, I would prefer partial. Complete, you may have to use a McGill forceps. Never, ever, 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 ever stick your fingers in their mouth. Don't do that. Transport rapidly. Call an ALS intervention if you're on a unit by yourself. Just BLS unit. Call for intervention because they're going to need some airway assessment soon, fast. PEs, you're going to have to give oxygen. Put them in a 45, 90, 75. I don't care what position you put them in. Whatever they say makes them feel the most comfortable. Okay, fine. Let's go. As long as it's safe, transport them to the hospital. Give them some oxygen. As you can see there, you want to make sure you hemostats, if you present it, clear the airway. I actually read that wrong. So if it's blood or anything like that, you want to make sure you try to suck it out, get it going, move on. Hyperventilation. We know we talked about anxiety attacks, anything like that may be our problem. Reassess the patient. Everything's going to be okay. Just need you to listen to me. Take slow, deep breaths. Don't do the breathing in the bag because you're filling them up with CO2. So that's not the good thing. That's not what we want to do. If it does help, take that patient, put their heads in the refrigerator. Now, I'm not trying to say shove their heads down in the deep freeze, but sometimes that cold, the cold humidified air that's coming out of there due to the pressure, the air environment change may help them drastically. That's what I say about that. On the environmental industrial exposure, remove them from the contaminant. Get it off of their clothes. You may need to figure out what kind of contaminant it is. If it's reactive to water, where you can't wash it off, you may have to dust it off. Um, that's a big thing that you need to know for sure. Figure out what what agent it is before you do anything to it. So that's very important. Treat with oxygen adjunct suctions. You just go off your patient assessment. If you did a good assessment to begin with, you're going to know what's up. Oh, wrong button. Foreign bodies, we talked about that. Aspirations, we did that pretty deep. Tracheostomy dysfunction. Oh, suction's the best thing I can tell you. They may need a mask, tracheostomy mask. Sometimes these patients may have them at their house because they may be oxygen dependent too. If so, make sure you take care of that. If not, you may have to call somebody to come in there and help you out before you can get ready to transport this patient because they may need certain mask devices. Asthma, blow-by, meter dose inhalants is MDI. Cystic fibrosis, that's the genetic. You're not really doing anything about that. Predisposed in children, so it's lung infections right here on the cystic fibrosis. Some of the symptoms range from congestion to wheezing, asthma. So they may tell you I'm having trouble breathing and give everything they may symptomize. You think it's a asthma attack, but it could be cystic fibrosis. Usually parents or caregivers call the EMS because the child had dyspnea and you want to suction and provide oxygen as needed. Most of the time, the family's very, very educated. If they do have cystic fibrosis, they already know. They've already jumped through hoops. They have these care providers at home. They may have home health. They may have all these things waiting there, or something has happened. Let's just say a power outage that's gone. That may be why. Um, so we are going to hit a couple of questions real quick, and I'm going to try to type them in the chat too. So I am going to type these questions in the chat real quick, and then I'll read it. And so give me a second, guys, so I can type this. All right, so there's your question. Which of the following respiratory diseases cause obstruction of the lower airway? Croup, asthma, epiglottitis, or laryngitis? What do y'all think? All right, Travis, you remember what we said about croup? Count the letters. Could be a virus. So let's think about that. So where is my? So that is croup causes upper airway obstruction. So think about that one. So we're talking about what is the lower airway. So C. Also, again, it's kind of, I'll give you that one. It's a good point, but it causes an upper airway. So what we want to look for is asthma. Asthma is the correct answer. And I'm gonna skip to the next one. Um, See, y'all already answered. I knew y'all were waiting on it. Um, Last one I'm gonna hit tonight. Oh, I got two more. I'm sorry. It helped if I could spell. All right. So bronchospasm is most often associated with asthma, bronchitis, pneumonia, or pneumothorax. Travis, you just multiple guess? I'm just messing with you. So I'll uh I'll give you some answers. So asthma is correct, but so the reason why some of y'all are going with bronchitis is that bronchitis is an inflammation of the mucous membrane in the bronchioli tubes. So I know we went over that, but and it's one of those you're like, man, I know we covered so much. I know those answers. Um, we'll talk about. Oh, there it is. So pneumonia is an inflammation of one or two lungs. So that's the reason why we may go with that one. But again, asthma is the correct answer. But I'll tell you what the rationale for pneumothorax is, and that's the presence of air gas in the pleural cavity surrounding the lungs, and that's what causes the pain when they take a deep breath, if y'all remember. So pneumothorax can be the air or gas. So we know it's pneumo because it's got it cuts off. So it got pneumo means air, hemo means blood, if y'all remember that one. So on our last one, we're going to hit, let me see here, flip to the right one. All right. Oh. So this one's long, so I'm just going to read it. I'm sorry if whoever can't hear me though. But a 70-year-old man recently had a heart attack and now complains of severe difficulty breathing, especially when laying flat. He is coughing up pink, frothy secretions. The patient is most likely experiencing A, acute right heart failure, B, severe left heart failure, C, an acute onset of bronchiolitis, or D, an acute pulmonary embolism. So that's a lot. I know if y'all want me to read that over, please let me know. Just type in there and we'll read over that one because that's a lot to hear and not be able to see it. All right, so I'll reread that. So a 70-year-old man recently had a heart attack and now complains of severe difficulty breathing, especially when he lays flat. He is coughing up pink, frothy secretions. This patient is most likely experiencing. So my initially thing is I wanted to go with like, oh man, this dude's having TB, but it's a frothy. So I think we're all. I mean, I'm gonna read y'all the answer because y'all are all going around there. But here's where a lot of y'all chose A or right-sided heart failure. So a acute heart failure causes a backup of blood into the systemic circulatory system, and it typically causes symptoms of peripheral edema. So you're going to see hands and feet are swelling. But the answer is B. So as a result of his recent heart attack, the left side of the patient's heart has been damaged. The left side of the heart is responsible for pumping oxygenated blood to the rest of the body. When it fails to do this, blood backs up into the lungs, resulting in pulmonary edema. Signs of pulmonary edema include dyspnea, especially when he lays flat, rapid and shallow respirations, and in severe cases, he starts coughing up the pink and frothy sputum. So B is a severe left heart failure. I know, Travis, it's a lot, and I'm not picking on nobody, and me especially trying to read that to you guys. So it's okay to miss that one. Um, Travis, I hate to hear that's what happened to your dad, man. I'm sorry. So y'all think about that. I know that's a lot, but what we went over, I encourage you guys to take the time and listen to this video again because there's a lot when it comes down to this. I tried to break some things down. I tried to make it a little bit understanding. I'm not sure that I did the best, but I know I talked about. I don't know if some of y'all saw the Facebook post, but I'm gonna put 4 questions in the Facebook group. So I encourage everybody to key in on that. I hope to have at least, I see there's 17 of you guys in here. I hope to have 17 of y'all respond, and then I will pick out, I'm not going to pick on you, but I'll pick on 4 of you folks to give me some explanation of why you chose the answers, basically like I did last time. Give you some questions. I like the feedback, so let's go back and forth with each other. I encourage that. I think it's really good for all of us, and kind of build it kind of is able for you guys to teach off each other. Does anybody have any particular questions on a certain topic, a certain thing that I may have just gone too fast? I want to. I know it's like 8:40, so that's another thing I'm trying to guys. We all got stuff to do, and we want to make sure that everybody's on the same page. You guys get it, you understand, and any questions from you folks, fine folks, may I add? All right. While I wait on that, so what I wanted to tell you is Rob sent me a message, and that says, the test time limits have been increased to 30 minutes for each chapter. So from now on, you guys have 30 minutes to do your chapter test. Not saying you got to do it right this second, but take your time. You got, I don't even know how many days you got to take it, to be honest. I'm sorry for that. But if you need to listen, y'all want to PM me on the side, hit me on Facebook. I'll be more than happy to go over some things, cite some of the stuff that will help you get a better idea of it. But best of luck in your test. Don't forget you have 30 minutes to take your test now instead of whatever time limit Rob had set before. So y'all are going to do fine. Other than that, I will type your code in. I will give you your code. And I hope y'all have a safe, warm evening. And I will see y'all. What is today? Tuesday. I'll see you Thursday night. And that will be the 18th. There's your code. Your code is BR549. That is your code for the night. And I'm going to sit here. I'm going to mute my mic for a few more minutes. If y'all have any questions or want to personally send me a message on the side, please do so. If not, best wishes, and y'all stay safe.